All right, picture this. You're on your shift, you're busy, and a patient comes in with an itchy, red rash. You know they need a topical medication, but when you think about all the options, creams, ointments, gels, it can feel totally overwhelming, right? How do you pick the one that's actually going to work?
That's the question, isn't it? The choice between a cream, an ointment, a gel, or a lotion. It might seem small, but it can literally be the difference between a happy patient with clear skin and a frustrating treatment failure. So let's break down exactly how you can make the right call every single time.
So here's our game plan. First, we're going to talk about why the base of a medication, what we call the vehicle, is so incredibly important. Then we'll quickly stock up your mental toolkit with the major types of drugs. After that, we are doing a deep dive into topical steroids and how to master their potency. And we'll wrap it all up with some real-world clinical pearls to keep you from falling into common traps.
You know, it's so easy to just look at the active ingredient on the tube and think that's the whole story. But with topicals, that's barely half of it. The real secret sauce, the thing that makes them work, is all about the delivery system.
See, for any of these medications to do its job, it has to get past this first line of defense, the stratum corneum. This is the tough outer layer of our skin, and it's designed to keep stuff out. So the whole game is figuring out how to get the drug through that barrier. And that delivery system has a name. It's called the vehicle. Just think of it like a car that's carrying the drug to where it needs to go. And the type of car you choose makes a huge difference. Is it a heavy-duty, occlusive vehicle that seals everything in, or is it a light, drying one that evaporates? That choice is going to directly impact how well the drug gets absorbed and, ultimately, how strong it is. Okay, so this is your first big decision. Ointments are greasy, and they're the most powerful vehicle because they trap moisture and really drive that medication into the skin. They are perfect for super dry, scaly skin. Creams are kind of the crowd pleaser. They're less greasy, they feel nice, so patients usually prefer them. Lotions are thin and watery, which makes them super easy to spread, so think about using them for large areas like the back or on hairy spots where an ointment would just be a mess. And finally, you've got gels. They're alcohol-based, so they have a drying effect, great for oily or acne-prone skin. But here's the catch. They can really sting if the skin is raw or irritated. If you remember one thing from this section, let it be this analogy. Think of an ointment as a raincoat for the skin. It's occlusive, it traps everything underneath, and it makes the drug more powerful. A lotion, on the other hand, is like a light t-shirt. It's breathable, it's light, and it's way less potent because it doesn't have that same trapping effect. Okay, so we've picked out our car. Now, who are the passengers? What are the actual drugs we're putting inside these vehicles? Let's take a quick look at the major drug classes that make up your topical toolkit. These are pretty much the big guns. First, you've got glucocorticoids, or topical steroids, which are your go-to for almost anything red and angry. You've got your antifungals for things like athlete's foot. Then there are immunomodulators like tacrolimus, which are fantastic for sensitive spots like the face, where you want to avoid steroids. Retinoids are key for things like acne. And of course, topical antibiotics like clindamycin or mupirocin for bacterial infections.
Now, of all those drugs we just listed, there's one class that you have to be really careful with: glucocorticoids. We're talking about topical steroids. And choosing the right potency, the right strength, is probably the single most important decision you're going to make when you're treating a rash.
So why is this such a big deal? Why not just hit every rash with the strongest stuff we've got and call it a day? Well, the answer comes down to one simple, crucial fact. Not all skin is created equal. And this is where it gets really interesting. The skin on your eyelids or face is incredibly thin. It absorbs medication like a sponge. If you use a high-potency steroid there, you're just asking for trouble. On the flip side, the thick, tough skin on your palms and the soles of your feet is like armor. You need a high or even an ultra-high-potency steroid just to get the medication to penetrate. Okay, let's make this super practical. Here is a simplified ladder you can just lock into your brain. At the very, very top, you have your ultra-potent clobetasol. Way down at the bottom, you have weak, over-the-counter hydrocortisone. And right in the middle, you have a total workhorse, triamcinolone. Honestly, if you can just remember one drug from each of these categories, you are way ahead of the game.
And here is a fantastic pro tip that'll make you look like a genius. How much do you actually prescribe? Well, remember this number, 30 grams. That is roughly the amount of cream or ointment it takes to cover an entire average adult body, one time. This helps you figure out exactly how big of a tube your patient needs. But, and this is a huge but, with that power comes some serious responsibility. Using these steroids wrong, especially the strong ones, for too long or in the wrong place, can cause real damage. I'm talking about things that don't go away, like skin thinning, stretch marks, and easy bruising. And listen, this one is critical. Be extremely careful with steroids around the eyes. They can actually worsen glaucoma.
All right, let's bring it all home. We're going to wrap this up with some practical, real-world advice, some clinical pearls and pitfalls to avoid that you can put into practice on your very next shift.
Okay, please remember this one. It is probably the most common trap I see trainees fall into. You see those combo creams? The ones with a steroid and an antifungal mixed together? Avoid them. The steroid might make the rash look less red for a day or two, but it lets the fungus have a party underneath. And if you use it in the groin area, it's a perfect recipe for stretch marks.
And here it is. This is the classic setup right here. You see this red, angry-looking rash in a skin fold, and that combo cream is just calling your name. Resist the urge. Treat the infection with a pure antifungal first. If you absolutely need to, you can add a separate, low-potency steroid for a couple of days to calm down the itch, but never use the combo.
So if we boil this whole thing down, what do you absolutely need to remember for your next shift? Here are 4 simple rules. 1. Match the vehicle to the skin. Ointment for dry scaly patches, lotion for hairy areas. 2. Match the potency to the location. Low for the face, high for the palms. 3. Avoid those combo creams, especially for a suspected fungal infection. And 4. Use it sparingly. A thin layer is all you need. And remember that 30-gram rule to help you prescribe the right amount.
So, we've gone from the vehicle to the potency and all the way to the major pitfalls. The whole point of this is to take that feeling of, uh-oh, what do I choose, and turn it into, okay, I got this. So as you head into your next shift, think about what we just covered. What's the one tip, the one key takeaway that you're going to use the next time you see a patient with a rash?